Now coming to the next question, welcome all after a small cup of tea. The main pancreatic duct joins the cystic duct and ultimately enters through ample of bladder. True. And no, it is not true. What will main pancreatic duct will be doing, doctor? It will be joining the common bile duct before draining into duodenum. That's right. And pancreatic polypeptide is typically elevated in all the endocrine tumors as a common marker is what need to be remembered. Now coming to hepatitis A. Generally it is very self-limiting illness, but it is also capable of causing hepatic encephalopathy, especially more so in the adults than in the children. It's much more troublesome problem in case of adult infection is what you have to remember. SLE, Streptococci, Epstein-Barr, they're all typically known to lead to immune complex mediated glomerulonephritis, unlike the good posture which is antibody directed type 2 hypersensitivity, not 3. Now a raised urea in spite of a normal renal function, what scenarios it will be like that? If there is a pre-renal azotemia like dehydration, or if somebody takes tetracycline or corticosteroid, any of them, but in acute renal failure there is a transient renal dysfunction which is definitely impaired. Coming to the nephron in a healthy kidney, it is the collecting duct and distal tubule whose function is basically retention of water, because that is a place where ADH will be working. Water deprivation tests are all basically to test the ADH action in order to diagnose diabetes insipidus. But my favorite topic, I don't know whether it is examiner's favorite topic or not, but good number of exams, AIIMS question bank, Barter, Liddell, Gitelman. They are the three entities which come. I need to still do some analysis of the DNB question bank before I say it is one among the 500 topics, but definitely it is my 500 best topics which I love to always discuss on. What is Barter? In this, the juxtaglomerular apparatus cells are hyperplastic, and typically their hyperplasia lead to hyperanemia, and that lead to development of hyperaldosteronism, which lead to hypokalemic, hypochloremic metabolic alkalosis, just like Conn syndrome. But the BP will be normal. And what is the main problem? Juxtaglomerular apparatus typically got hyperplastic. That is the problem. Now coming to Liddell's. In Liddell's, the patients are hypertensive basically, which differentiates Liddell from that of the Barter. If we go more deep into this topic, there are a lot of things to discuss. So I just leave, you can review in the acid-based disturbances video in our regular video library. You will come across a lot of sessions we discussed about Barter, Liddell, Gitelman, everything. Now coming to multiple sclerosis, abnormal visual evoked potentials. A young, sweet looking female comes with multiple neurological deficits, difficulty in gait, etc. You are suspecting multiple sclerosis. She has Lermit sign positive, where there is a shocking electrical like pain in the back whenever she is bending forward. So what is how do you prove that she has multiple sclerosis? One is oligoclonal bands in the CSF. Second is you will order for a visual evoked potentials which will show a decreased conduction if you do the visual evoked potentials. That's how we basically evaluate. Now tell me, doctor, which organism is optochin sensitive, optochin resistant? Today only let me clear you the gist of microbiology. Optochin sensitive, optochin resistant. Streptococcus pneumoniae, as mentioned by Anuja from Pune. Dr. Shweta also agrees Streptococcus, and Kirti says Saprophyticus is resistant to optochin. Very good. Streptococcus pneumoniae is sensitive, Viridans streptococci is resistant. It is the optogen sensitivity which is a differentiator. Bronchus, breast, stomach, prostate. Thyroid and kidney, they are all known to produce the cerebral metastasis, not the colon. Ataxia telangiectasia predominantly is autosomal recessive. It is not autosomal dominant. In Kawasaki, mucocutaneous lymph node syndrome of vasculitis, we give IV immunoglobulin to treat the vasculitis. Once more, today only market doctor, vasculitis, Church-Ross, vaginous, cryoglobulinemia, polyarteritis nodosa. One question. Without that there will be no paper, whichever session you belong to. Now delirium tremens is mainly by chlorodiazepoxide, is the one which is basically used to treat. A 5-year-old boy, no interest in other children, and he spends hours lining up the toy car, spinning their wheels, but does not use it for the make-believe play. Typical of autism, lack of interest in social interaction, severely impaired verbal and non-verbal communication, etc., etc., is what need to be remembered. Tell me, doctor, should be answered. Rectangular crystal-like cytoplasmic inclusions called Rinke crystals. Where do you find them? In which kind of a tumor? Oh, very good question. Why not it is red? Is it because of the boy or girl? It's a good point, we'll take up at the end. Okay. Rinke crystals, which tumor? Who will give me correct answer? That's right, our online students. Kriti says Hylas, Swapna says Hylas, Kakinada says Leydig cell tumor. Right. Rinke crystals are typically found. Factitious disorder versus malingering. What is the main difference? Last time we discussed. The main idea of factitious disorder is to gain some financial advantage by assuming a sick role. That is the thing which characterizes the factitious disorder, which is not synonymous with the objectives which motivate malingering, like avoiding work, unpleasant consequence, they are missing in the factitious disorder. The reverse is true. That's right. Now, coming to nocturnal erections, when do they basically occur? Typically, erection in the night is a part of the REM sleep, and those who are depressed, REM sleep component will be lesser, and hence insomnic people, their nocturnal erection will be lesser in the males. Now coming to the lichen planus, the mucus involvement is found even without the skin involvement, very much possible. And what is the mucus involvement that you have? Those characteristic fine white lines called Wickham striae is one of the very characteristic feature. What precipitates a guttate psoriasis is an important question. Streptococcal infection, sudden stopping of the steroid therapy and use of the anti-malarials can precipitate the psoriatic episodes in guttate psoriasis is what need to be remembered. Now coming to the syphilis, the primary syphilis lesion is definitely infectious. Who said non-infectious? That's how all the sailor boys got it when they have gone a long sea navy. Now leprosy typically is not a highly infectious disorder. All the remaining statements are true. Thyroid-like appearance of kidney, thyroidization of the kidney, where colloid substance get accumulated in the renal cells, in the tubular cells. Where do you come across this condition? We discussed it in one of our, same question was popped up with an image in one of our Sunday test earlier. Excellent. Dr. Anuja shoots the answer like a mirage plane. Chronic bacterial pyelonephritis. There is a colloid accumulation which lead to what is called as thyroid-like appearance of the kidney is what need to be remembered. Now coming to the surgical patient, in a 70 kg man, what is the minimal water maintenance which is required? 70 into 0.5 ml per kg per hour into 24 hours plus 750 ml per 24 hours makes it 1590 ml per 24 hours. Your maths must be little good to answer this question. Now doctor, sutures. Absorbable sutures will result in infection less often than that of the non-absorbable sutures. Absorbable are made up of collagen is true, all the remaining things are true. Now only one side of the bowel is trapped in the hernia, then what do you call it as? Richter's, typically called Richter's hernia. Now coming to the inguinal canal, what is the anterior wall made up of? External oblique epinurosis typically. In Hasselback, it is laterally by inferior epigastric artery, inferiorly by the linguine ligament, and superomedially by the lateral border of the rectus is the typical Hasselback. Whereas HER2 new gene is amplified, typically in the case of the breast cancer, as all of you know very well. Then RAS oncogene, colon cancer. C-MYC is typically in solid tumors. So that's what need to be remembered. Give me one confident answer, doctor. Spikes on the basement membrane, dome-like subepithelial deposits. Typically, in which glomerulonephritis do you come across? If you do glomerulonephritis topic wrong, my soul will be heaving in the graveyard in misery. Array, this much I could not be able to impress them that they need to read before exam. Excellent. Typically, subepithelial deposits, no? Spikes and subepithelial deposits. PSGN is one answer, MPGN, membranoproliferative is another answer, but you need to remember membranous glomerulonephritis classically is the answer. Now coming to colon carcinogenesis, there is a correction in the key. Instead of answer C, make it D. APC gene is typically lost early in the adenomatous polyposis, not late. So when is DCC lost? KRAS is affected. All these things you need to follow the literature. Now coming to the esophagus, what is the epithelium, doctor? Squamous cell epithelium, except the distal 1 to 2 centimeters, which is columnar. Now in peptic ulcer, if there are pyloric channel ulcers within 3 centimeters of the pylorus, frequently they will be resistant to the medical therapy and they need surgery as the treatment for you to treat them.